So today we'll be discussing physiology and pharmacology, and then we'll do some anatomy if the others come, or slash if we have time. So to start with, we're going to be discussing the cardiac cycle. So the cardiac cycle really just refers to the events from the beginning of the one heartbeat to the beginning of the next heartbeat. So it's a cycle. And it's initiated by a spontaneous action potential in the sinus node. So if you can remember from last or 2 weeks ago, the sinus node is in the lateral part of the right atrium. There'll be a spontaneous action potential in that right atrium that'll depolarize the atria. They'll depolarize, then contract. Their blood will fill into the ventricles. Then the ventricles will depolarize and contract, and the blood will be shot out. Some important steps are the delay between the atria and the ventricular contraction. The atria act as primer pumps for the ventricles, as we discussed last time, bit of revision. And the ventricles are the major source of power moving blood in the circulation. So there's two concepts. We've got to really start with some definitions, and these are diastole and systole. So essentially, another way to describe the cardiac cycle is the duration of diastole and systole. Diastole refers to the period of ventricular filling. Sorry about that. Diastole refers to the area of ventricular filling. So that's when the atria are leaking blood into the ventricles passively, first stage. Second stage, atria actively contracting blood into the ventricles, and that's the filling stage. So the ventricles are completely relaxed. Then your next stage is your systole phase, and that's the period of ventricular contraction when you're having your blood ejected from the heart. An important note to know is that the cardiac cycle is a reciprocal of the heart rate. So if the heart rate is 60 beats per minute, then the duration of the cardiac cycle is 1 over 16 minutes per beat. Do you ever talk about it in terms of atrial systole or diastole, or just ventricular? It's just ventricular. What was the difference to atrial systole? You don't really talk about atrial systole and atrial diastole. I hope I didn't say atrial by accident, because I got a couple of questions on that. The reason why, we'll talk about it in a second, is essentially that the atria don't really matter in terms of if they contract or not. So, it's the next slide, wonderful. So I'll come back to that slide before, but in your atria, 80% of the blood is flowing from the atria to the ventricles passively. And when they contract, it only accounts for 20%. So clinically, that's usually asymptomatic. And regardless of which, the filling is from the venous system. So it's continuous into the atria. So you don't really talk about systole and diastole in terms of the atria. It's really just referencing ventricular filling and ventricular contraction. Another reason why is they also have to do with the valves of the heart. And you don't really talk about the valve from the superior vena cava to the right atrium. Like, that's not really a valve that is involved in this process. Whereas you'll see it's quite complicated. We'll talk about it in a bit, how the valves are involved in diastole and systole. So I hope that makes sense. And clinically, if you increase the heart rate, you decrease the cardiac cycle, decrease the duration of the cardiac cycle, because the beat is happening more quickly. But what's important is diastole decreases by the great diastole. I can't say any of these words. Diastole decreases by the greatest percentage. So you're mostly going to not have complete filling. So if you have a really rapid tachycardia, which means really rapid heart rate, your main problem is going to be the heart is contracting regularly enough, but it's not being filled with enough blood. So diastole is disproportionately affected. So just to discuss atria as primers and why we're not talking about atrias in terms of systole and diastole, is during diastole, which is when the blood from the atria, okay, so this is a ventricle. This is from the atria. During diastole, these valves are open. If we're in the right atrium and this is a right ventricle, do you know what valve this would be? Any ideas? So we've got some tricuspids. So interesting, left atrium to left ventricle. Mitral. Yeah, good. So yeah. Did I say right atrium to right ventricle when I asked the question? Okay, that's my bad then. Then everyone got it right. Good. So right atrium to right ventricle is tricuspid, and left atrium to left ventricle is mitral. So really good. So 80% is just flowing passively. So the atria aren't even contracting, it's just flowing through anyway. Whereas 20% of the blood is due to active contraction filling the ventricles. So clinically, that means that usually if people have dysfunction of the atria, it's not going to present clinically because the heart pumps more blood while resting. But when you're exercising, it's more noticeable because the amount of blood you require increases. And so the 20% makes a difference because you need as much blood. The demand exceeds the supply. So all of the supply matters. So that can present with shortness of breath. Hope that makes sense. This is a little graph that we're going to come back to. So this is essentially all you need to understand from this lecture. It has all the concepts in it. Granted, there are a lot of concepts. This is just, if you need to revise, look through this. Generally, when we discuss this, we're discussing the left side of the heart. It is all relevant to the right side of the heart, but it's usually not as clinically relevant. So usually you're talking about blood being pumped into the aorta as determining your blood pressure, rather than into your pulmonary arteries, which is much harder to assess clinically. So this is a bit intimidating. On the right, you have your key, and this describes what all these lines represent. So if we look at, I just told you that 80% of the ventricle, 80% of the filling of the atria to the ventricle is passively. A way we can see that this is true is we know that when the atria contracts, the pressure is going to increase because there's less volume for the same amount of like space. So you can see here, this little increase here in atrial pressure is related to atrial contraction. But over here, the atria is quiescent essentially. It's completely passive. And this is when this ventricular volume of blood is increasing the most by 80%. Then there's a contraction of the atria and there's a little surge in ventricular volume for about 20%. So we're going to be talking about this a lot. I'll be coming back to this a lot because it's really got everything here. So now we're just going to talk about the valves a bit. So the most important concept to know about the valves is that they are passive. Valves aren't like muscles contracting to block things off. The reason valves will close or open is due to relative pressure differences on either side. So if we look here, if the pressure behind the valve is greater than pressure in front of the valve will open and blood will flow forwards. Whereas if the pressure behind the valve is less than pressure in front of the valve will close, and this should prevent backflow. So if we think for a second, okay, these are the answers, so I'll just ask you. If we think for a second about the heart, during systole, so this is my left atrium, this is my valve, this is my left ventricle. During systole, when the ventricles are contracting, do we think the mitral valve will be open or closed? Closed, really good. And the reason why they're closed is to prevent regurgitation back into the atrium. During systole, we want to pump the blood from the ventricles into the aorta, as much blood as possible, as efficiently as possible. So you don't want, when this ventricle contracts, sometimes blood will try and push against here, and you don't want it to flow back. Likewise, during systole, there's a lot of blood in the ventricles. So it's a high pressure system. So the pressure here is greater than the pressure on this side. So the valve is closed due to that relative pressure difference. Whereas during diastole, when there's filling, you obviously need this valve to be open. And the reason why it's open is the pressure in the atria during filling. There's more blood in the atria because the ventricle have just shot out all the blood. So they're essentially empty. So the pressure in the atria is greater than the ventricles. So this valve will open. Does that all make sense? Yeah, that's true. So someone said, is it right to say that the mitral valve will always be open if the aortic valve is closed? So that's a good question. It's good in theory. There's just one exception to it. So sorry for these really crude drawings, but this is a mitral valve. This is the left atrium, mitral, left ventricle. And then let's say this is the aortic valve. So what's important is, yes, while it is true that during systole, the aortic valve will be open and the mitral valve will be closed. And during diastole, the mitral valve will be open and the aortic valve will be closed. So they'll be opposite. There is a period in time when both of them are closed at the same time. And that's essentially just, if you imagine, once you've pumped all the blood out of the ventricle into the aorta, you've got like a great volume of the sac, but there's not enough blood in it. So there's going to be a reduced negative pressure in that sac. So it's going to slowly decrease. And while it's slowly decreasing, both these valves will be closed. Likewise, once this has been filled, the atria has filled the ventricle, the pressure will be increasing, but there will be a moment when both these valves are closed, when it's called isovolumetric contraction, where the pressure in the ventricle will increase due to contraction. So it's true they're always opposite, but sometimes they're both closed. That makes sense. We've got more slides on that in a second. So I'll go through that and I'll ask if it makes sense then as well. So these are, let's have a look. Yeah, thank you. So let's have a look. So semilunar valves are what we call our aortic valve and our pulmonary valve. The aortic valve separates the left ventricle from the aorta, while the pulmonary valve separates the right ventricle from the pulmonary arteries, from the pulmonary trunk, really. Because does anyone know what the difference between the pulmonary trunk and the pulmonary arteries? So the pulmonary trunk will become the pulmonary arteries. So that's important when you look at it on a CT. Some anatomy before we've done anatomy. The atrioventricular valves refer to the mitral between left atrium, left ventricle, tricuspid, right atrium, right ventricle. And this is just really summarized what we've said before. Closed during aortic and pulmonary are closed during diastole to prevent black flow from the arteries to the ventricles, from the aorta to the ventricles. And likewise, yeah, we've discussed that, I think. Is everyone okay if I move on? Yes, okay. If that doesn't make sense, let me know and I'll just do it again, because sometimes you can understand it in a moment and then forget it in a second. So that's fine. So the ventricles moderately increase in pressure in atria during systole. So this is in description of the ventricles. To understand the ventricles, we need to know what's happening in the atria, because the atria are the primers for the ventricles. So during systole, there is still a moderately increasing pressure in the atria. Even though the valve is closed, they're just slowly getting filled with blood. And that's the reason why the pressure is increasing, is you have a decreased AV valve, so there's no outflow, but you have an increased inflow, so the pressure is increasing. Once systole is over, ventricular pressure will start to fall. So once, that should make sense because you've shot all the blood out, so there's less volume in that same amount of space. And so you have increased atrial pressure and decreased ventricular pressure. As a result, your AV valves will open and allow blood to fill from the atria to the ventricles. And that's referred to a period of rapid filling of the ventricles. During diastole, we've kind of divided this section in thirds. You can see here, this section is diastole. You can see it's marked when the AV valve opens. This over here is ventricular volume, this blue line. And this over here is atrial pressure, this dotted line. I'm pretty sure. Yes, it is. So you can see the first third is marked by rapid filling. Like that's a really exponential high growth. That's all passive. The second third is a small amount of filling, so it starts to taper off. And the final third, the atrial contract and lead to that 20% increase. So a clinical note is that high blood pressure or diabetes mellitus can contribute to ventricular stiffening that can cause cardiac fibrosis. If the ventricles can't expand, that means less blood can fill the ventricles during early diastole and you have reduced eventually output. So that's a concept of preload, which we'll talk about in a second, which essentially means how much blood is filling the ventricles. But if the ventricles can't expand, then not as much blood can fill, like a balloon. We haven't done ECGs yet, and they do kind of throw you in the deep end with this. But in an ECG, you have something called the PQRS-T complex. So this is the P complex. This is QRS complex. And the T complex is just over here. The end's just been cut off. But these are all related to stages of the cardiac cycle. So the ECG is essentially telling you the electric current flow through the heart. So if we look at this P wave, it's caused by the depolarization of the atria. And this makes sense because you can see as soon as this occurs, there's contraction of the atria with their increased pressure. So that makes sense. We've done P wave. It's caused by depolarization followed by atrial contraction. The QRS wave is caused by depolarization of the ventricles. So we have our QRS here, and it's depolarizing our ventricles. And I'll show you the original one. We have our QRS here. It's depolarizing the ventricles. And so you can see our ventricular pressure is increasing because it's contracting. So the space is declining and it's being shot out. So it's QRS refers to depolarization, but it's followed by the contraction. The T complex refers to the repolarization of the ventricles or their relaxation. And it's goes just slightly before the end of ventricular contraction. So it's when the fibers begin to relax and the blood is being shot into the aorta. How are we? Are we struggling? It's pretty hard. But I essentially am going to summarize that all again in a different way. So now, take 2. Now we're going to talk about the cardiac cycle in terms of its phases. So there are really 4 phases of the cardiac cycle. We split one in 1A and 1B. And we've really discussed the passive filling of the ventricles. We've talked about that, and we've discussed atrial contraction. Now, this is someone's question regarding can the valves, if one valve is open, does that mean the other valve is closed? Which is usually true. Just they can also both be closed, and we'll be talking about that in these 2 situations. Isovolumetric. So let's keep going. Maybe I'll talk you through this. So here you can see how the cardiac cycle is cycling through diastole, systole, diastole, systole, diastole, systole, diastole. And you can see that the start of the cardiac cycle is with the passive filling of the ventricles. So here is during diastole is the passive filling of the ventricles. It's passively filling for 2/3. Then the atrial pressure is going to rise a little bit in relation to atrial contraction, and the volume will increase a bit. Then you have this period of isovolumetric ventricular contraction. This is when your valve closes. So what do we think is going to be the first valve that closes that's going to facilitate systole? Tricuspid. Yeah, exactly. Tricuspid or mitral. Really good. So that's so you don't have backflow into the atria. So we have this period of isovolumetric contraction where both valves are closed. And during this time, the pressure in the left ventricle, which is this, I'm colorblind, I think that's pink. This pink line is going to increase substantially. So the volume isn't everything is closed. The volume itself of liquid isn't changing, but the vessel is becoming more contracted. The filaments are sliding over each other and some pressure is increasing. This will occur to the point of ventricular ejection. But just before I say that, I should say that every time a valve closes, it makes a sound. And that's what you hear when you auscultate the heart. So the first heart sound is lub, caused by closed of the tricuspid or mitral valve. Second heart sound is closing of the aortic or pulmonary valve. But just back to this. So we have our ventricular pressure rising during this ventricular contraction phase. Then what will happen? So it's not a typical contraction, it's just increase in pressure. So the heart is actually physically contracting. The reason why it's isovolumetric is there's because it's a heart, all the fibers are in circles. So it's not like, it's just more tension. And if you remember, if you have like lots of air in a really big room, you have low pressure. As the walls of the room come closer together, the pressure increases because the particles hit that room more quickly. So it's a similar concept. So the ventricles of the heart are actually physically contracting, but both valves are closed. So there's no change in the liquid. So that's just contracting. So the pressure increases in that ventricle. And the reason why you want that pressure to increase in that ventricle is you want the pressure in the ventricle to be greater than the pressure in the aorta. And the reason you want that is so that blood can flow from the ventricle to the aorta. Because if you look here, if you don't have that isovolumetric contraction, the ventricular pressure is substantially less than the aortic pressure, which means if you open that aortic valve, blood is going to flow from the aorta to the ventricles, which you don't want. So you need to close it until the pressure in the ventricle is greater than the pressure in the aorta. And only then does blood flow through, and that marks systole, when blood is flowing from the ventricle into the aorta. So hopefully that all makes sense. Then we have isovolume. After this ejection phase, we have isovolumetric ventricular relaxation. Similar thing occurs. So you have your aortic valve is going to close. You're going to hear dub, which is your second heart sound. And this is when the pressure in the aorta is going to be greater than the pressure in the ventricle. That means due to the relative pressure, the valve will close. But the pressure in this aorta is still greater than the pressure in the ventricle. And you can't have that. So you want the heart to expand. So you want it to relax a bit. The room is coming out of it. And that way you can get to a stage where the atrial pressure is greater than the ventricle pressure. So the atria can fill into the ventricles. So that's more of a complete, hopefully everything is coming together a little bit. So as we discussed, isovolumetric contraction refers to the period between the AV valve closing and semilunar valves opening. Semilunar referring to your aortic and pulmonary valves. No emptying occurs. There's no flow of blood. There's just tension is increasing, but very few shortening of cardiac fibers. So that this is just a buildup of tension. Yeah. Does that make sense? Because it's not like muscles where it's like this filament becomes shorter. It's all in like, it's all intertwined and branching. So as you increase contraction, you increase tension. So the first heart sound is love, which is a closing of the AV valves, and that will occur with ventricular pressure rise sharping very rapidly. And this is preceded and can overlap with QRS complex. So I reckon these are quite high yield, these little slides describing what happens in each phase, because they might ask you, when does the QRS complex occur? What's it associated with? And you should know isovolumetric ventricular contraction. When does the first heart sound occur? You should know isovolumetric ventricular contraction. Ventricular ejection is a bit more messy, sorry about that. So ventricular ejection occurs when the ventricular pressure typically is greater than 80 millimeters of mercury. We usually talk about the left ventricle, it also applies to the right ventricle. And as we said before, it's when the ventricular pressure pushes semilunar pressure open, and blood will be ejected into the pulmonary or aorta. About 60% of blood in the ventricles at the end of diastole will be ejected into during systole. So that might be, you might have thought, well, all of the blood is going to be ejected to be as efficient as possible. But that's not true. Only 60% of the blood in the ventricles is actually going to be ejected out. The rest is just going to stay there. And there is a term for that we're going to discuss in a moment, but that's kind of an important concept. Even though that happens, you still have more than enough blood to fulfill the needs of the body at rest. Whereas when you exercise, sometimes you might need to eject more of this blood. But of the blood ejected, 70% is in the first third of ejection period, which you can imagine because there's the most amount of pressure at the start, period of rapid ejection, and then 30% in the last 2/3. And this is preceded with the T wave. So ventricular ejection is preceded by, so this is a T wave. So it occurs kind of with ventricular ejection. Let's see if so this is a T wave. This is our ventricular ejection. So they kind of occur, they kind of associate with each other. because the T wave is going to be repolarization when the ventricles relax. So that's going to be the end of this ejection phase. I'm sorry, this is ugly. Isovolumetric relaxation, but it's essentially the same as contraction, is when the ventricular pressure is less than the aortic pressure, the aortic valve shut. So once enough blood is flowing through that the pressure is now shorter, remember that the arteries have especially elevated pressure and are distended because they've just been filled. So the ventricle is going to seal because the pressure outside is greater than pressure inside, and the ventricular muscles will start to relax. So there's less tension, even though the volume itself doesn't necessarily change. So it's about the tension. If you imagine a balloon, do you know how if you leave a balloon out for a really long time, it gets really like saggy and like very loose? If you imagine you just blow up a balloon to that same volume that you've blown up that saggy balloon you've just left, one has substantially more tension than the other one, even though the volumes aren't necessarily different. So that's kind of a crude analogy to explain how that works. But eventually your intraventricular pressure will fall back to low diastolic pressure. You'll hear dub due to the atrial valve to the valve closing, and the AV valve will open. This is important. The first heart sound you can hear occurs during isovolumetric contraction, which is closing of the AV valve. The second occurs during isovolumetric relaxation, which is closing of semilunar valve. This is all you need to know. So are there any questions at all? Do you want me to go through this? Should I go through this as a summary one more time? Each stage. Yeah, okay, no worries. So we're going to start in phase 1A. Phase 1A refers to the passive filling of the ventricles by the atria. You can see this occurs. We're going to start at this period over here, the start of diastole. You can see over here that the atria are quiescent, which means there's no electrical activity. There's no electrical activity here either. And the ventricle is passively filling to about 80%. Then you're going to have your P wave. And your P wave is going to mean that your atria depolarize, which means they're going to contract. And so the pressure is going to increase. As a result of that increasing, blood is going to be pumped into the ventricles. Once blood has been pumped into the ventricles, remember there's a delay between the electrical signal between the atria and the ventricles due to that AV node and bundle. Once that's been delayed, you'll have this QRS complex, which refers to the depolarization of the ventricles. Once this occurs, it means the ventricles are going to start to contract. And you can see that contraction in terms of the increase in ventricular pressure. We're now in the isovolumetric contraction phase, which means that there's more tension in the ventricles, and tension and pressure have to build until the pressure in the ventricle exceed the pressure in the aorta. This is so the valve can open. Right now, there are no valves open. The AV valve closes here as soon as the ventricular pressure exceeds the atrial pressure. So you've got to build tension, pressure, until the pressure in the ventricle exceeds that in the aorta, in which case you'll have your ejection period. In your ejection period, your ventricular volume will start to decrease as blood is pumped into the aorta. That's going to continue to occur until you have, I clicked by accident. That's going to continue to occur until you have your relaxation of the ventricles, shown by this T wave that mark the end of systole. Your aortic valve is going to close about here as soon as the pressure in the ventricle is less than the pressure in the aorta, and that's going to make your dub, or second heart sound. Then you're going to have a period of isovolumetric relaxation in which the ventricles begin to relax to a point. Both valves are closed at this point. Ventricles are going to relax until the pressure in the ventricle is less than that in the atria, and you will have begin phase 1A again of the passive flow of blood from the atria to the ventricles. That is all you need to know. Does that make sense? Any questions? But yeah, you can see, like, hopefully you've learned a lot. Like before, this is super intimidating, and it still is probably, but now you know what each term means. you know what each of these lines represent and you can relate them to each other. So hopefully that's good. Now we're going to talk about cardiac output and related content. So this is more directly, like more mathy, more to the physiology. We have a couple of concepts and definitions we need to go over. The first one is end diastolic volume. So this just refers to the volume of blood in the ventricles at the end of diastole once they've been primed by the atria. Now, if you remember, I told you that only 60% of the blood usually in the end diastolic volume is pumped into the aorta. The remaining blood is called the end systolic volume, which is the volume of blood left in the ventricle after ventricular contraction. So mathematically, the way this would have worked is people would have been like, how do I know how much blood is being pumped into the aorta from the ventricles? And what you do for that is you take the total amount of blood initially, and then you subtract the total amount, the blood left over to know how much blood was thrown into the aorta. Does that make sense? So stroke volume refers to blood ejected with each ventricular contraction. Yeah, awesome. So you take end diastolic volume, which is the total amount that was filled during diastole, and you subtract how much is left over to know how much was thrown out. Ejection fraction is used more clinically, and it's the proportion of end diastolic volume that's ejected. I told you it's usually 60%. To figure that out, you take stroke volume, which is the amount of blood ejected into the aorta, and you divide it by the end diastolic volume, which is how much blood there was there to begin with. Does that I get why the words are confusing, but is that okay? Okay, good. I was confused with that at the start, like particularly this. I don't know why I couldn't follow. But hopefully that's how much is ejected. That's how much there was to begin with. That means how much percent is ejected. This is showing you how stroke volume, or the amount of blood ejected, can be affected by a variety of different factors. So the main ones we're going to talk about the main one we're going to talk about are venous return and sympathetic stimulation. Before we do that, these are two concepts that are kind of assumed knowledge. So I just want to make sure that they're said quite explicitly. So there's two concepts called preload and afterload. So preload refers to the degree of tension on the muscle before it contracts. So this is relating to the ventricle, and is usually considered to be end diastolic pressure. In other words, how much pressure is the end diastolic volume, or the blood from the atria to the ventricles, exerting on the ventricles? And this is usually influenced by venous return. So if you have a lot of blood returning to the heart, because let's say you're running really fast and the valves in your legs are like contracting and they're pumping the leg up to your heart, then you're going to have increased diastolic volume and increased preload. And the heart is a bit like a balloon. So as you increase that preload, or that amount of fluid in the heart, it's going to expand. And that means when it contracts, it's going to contract with even more force, even more blood is going to be exerted out. Afterload kind of is, you can think of it as a resistance. So it's the pressure in the aorta the heart must overcome, but more generally considered as the systemic resistance in the body the heart pumps again. So that's like Ohm's law sort of thing. So voltage is equal to current times resistance, which isn't helpful. So that means that the heart is like the high potential of this circuit around the body, and the flow of which the blood goes through the body is also determined by the resistance. And resistance is often caused by vasodilation or vasoconstriction of vessels. So vessels vasoconstrict, often there's more peripheral resistance, so the current is going to increase to accommodate for that if you want to have the same pressure going along. Don't need to know that as well, just know afterload pressure, preload. If you have increased preload, the heart's going to contract harder. So then you have this really important concept of cardiac output, which is just the volume of blood pumped each minute. And it is a function related to the heart rate and the stroke volume. As you increase demand on the body, let's say you increase in exercise, you increase cardiac output. And you can do that either by one, stimulating the sympathetic nervous system, which increases your heart rate, which increases your cardiac output, by increasing your sympathetic nervous system, which increases the contractibility of the ventricular muscle, which increases your cardiac output, or increasing venous return, which increases your end diastolic volume, which increases your preload, which means there's going to be a greater amount of blood going out per contraction. So your stroke volume will increase, so your cardiac output will increase. Does that all make sense? A lot of concepts. Please tell me if you want me to explain something more. Then we have increasing cardiac output. Again, can either affect heart rate or you can affect stroke volume. You can affect heart rate by increasing sympathetic activity, decreasing parasympathetic activity, or increasing circulating adrenaline or any other catecholamine. Stroke volume can be increased by stretching the ventricular sarcomeres. So we're going to talk about this mechanism, but essentially all that's saying is if you increase end diastolic volume, you'll have the heart's going to balloon up, going to contract more, or you can have sympathetic nervous system stimulating beta receptors, which increases contraction. So the Frank-Starling law essentially just says that the ventricular muscle acts like a balloon. The more they are filled, the more they are stretched, and the more they are stretched, the greater the force of contraction. The greater the force of the contraction, the greater the stroke volume, or the amount of blood going out per systole, per beat. So this is just a graph relating end diastolic volume to stroke volume. Exercise in venous return. Increased venous return means that end diastolic volume increases, which means there's more pressure on the ventricles with stress, which means a larger force is generated by contraction and there's an increased stroke volume and therefore cardiac output. Now we're going to talk about sympathetics and stroke volumes, which is this final part. Usually when you have the contraction of these muscles, a depolarization will open L-type calcium channels, lead to a calcium influx, which will stimulate some protein channels that lead to increased calcium release from the sarcoplasmic reticulum. All you need to know, sympathetics stimulate the beta receptors, which increase the calcium release and increase the calcium reuptake back to the sarcoplasmic reticulum. That means there's more calcium more calcium available to cross-link with lectins. The troponin, that means you have greater actin-myosin cross-links and a greater force of contraction. That's the end of the physiology. Does that, any questions at all? Does that make sense? You're allowed to say no. Okay, all good. Good. Hopefully, yeah, when you hear the lectures, hopefully that'll all be reinforced. So, Katja, do you want me to share screen or would you like to share screen?
I actually don't really mind. Whatever you think is easier.
I'm happy to share what we're here. Present.
Nice.
Oh, 1 second. Sorry, someone asked me to go over Frank-Starling again.
Oh, yeah. Do you want to do that?
So, Frank-Starling. All Frank-Starling says, it's a fancy name. All it means is that the ventricles are like a balloon. It means that the greater amount of fluid filling up the ventricle, the more it is stretched, and the more it's stretched, the greater the force of contraction will be. So Frank-Starling law is this relationship. As end diastolic volume increases, or the amount of volume in the ventricles increase, the stroke volume, or the amount of blood released when it contracts, is going to increase as well. Does that make sense? And your end diastolic volume usually increases if there's increased venous return, which, for example, can occur in exercise when you're running, the valves in your legs, the compartments in your legs contract. Why does it taper off at the end? So it's a good question. I think it's because there's like a limit tool. Also, how to study for the CIP, lol, yeah, we can do that too. So why does it taper off at the end? I think it's just there's a limit, like it can't stretch forever. And the more it's because you think about the actin-myosin crosslinks, you want maximal coverage. So when it stretches, it has the optimum amount of surface area. And that's why there's an exponential growth here. And then it slowly tapers off as these so if this is how it usually is. This is how it usually is. And then we're stretching the heart. Sorry, my fingers aren't very good to explain. If you think about the maximal surface area between these two is when they're like this. As you increase the stretching, as you increase the stretching, there will be a point where you're actually losing surface area, where you're pulling the troponin and myosin complexes apart. And so the volume of contraction will be reduced. Whereas the overlap, when it isn't stretched, when they're completely close together, also isn't optimal. So there's a middle point where just over here, this highest exponential growth, where the surface area between the myosin and troponin and the myosin and the, oh my God, the myosin and the other one, the actin and the myosin are maximal. And when they're maximal, that's when you'll have the greatest force of contraction. Before that, it becomes less optimal. Yeah. Any other questions? Great, thanks. I hope that makes sense. I'm sorry I forgot what the word actin was. That's terrifying. Boy, I scroll screen. Okay, let's do some fun. Yeah, Kat, whenever you're ready.
Sweet. Also just like quickly while it tapers off, the stroke volume can only be like, it can't like go on indefinitely, right? Because that's like how much is pumped out. So like a less scientific explanation is like it has to have a limit of how much blood can come out of the heart, like due to like space constraints even. But yeah, okay, cardiac drugs. Next slide, David.
I'll just add one more thing. There's actually,
yeah, go.
That's what, so I don't know if you've learned about heart failure yet, but that's a type of heart failure, is when the muscles of the heart are kind of atrophying. And so although it's expanding quite a lot, there's not sufficient muscles. It's expanded too much for the muscles to actually be able to contract. But that will come later. So cardiac drugs.
Lovely.
The other type of heart failure is when there's hypertrophy and the heart has to work too hard. But yeah, Kat's turn.
There's lots of heart failure. I love how it's kind of funny in year one, like I feel like the most high yield is like these last couple of weeks. For cardio comes up a lot. So be on the ball for this next kind of 3 weeks. So for cardiac, you'll have 6 lectures. We'll be covering the first 2 today. So I think David will go through atherosclerosis, and I'll go through the cardiac biomarkers one. It's relatively low yield. Like there are a couple of like key things that do come up. Everything else isn't too important. So I'll just emphasize like the bits that do come up again and again. That said, though, all the drugs you learn this year will come up next year and like in different like systems as well. So if you understand or have like a basic understanding of each of like the class of drugs, it helps a lot next year. Next slide. So specifically today we'll be talking about ACS, which is acute coronary syndrome. When you think like coronary, just think like blood supply to the heart, because you have like the coronary arteries, and AMIs, which is a heart attack. And then we'll be talking about troponin. So if you remember one thing from today, I want you to remember troponin, and like all of David's lecture, but troponin just from mine. And then there are some other biomarkers, not really that relevant. Then we'll talk about BNP and C-reactive protein for heart failure. And then talking a bit about changes to the heart. Nice, next one. So ischemia is just our really broad term for reduction of blood flow, specifically by consequence of that is oxygen to an organ or a tissue. And it can be from 2 reasons. It can be from a blockage from the inside. So on the left, you see that little like clot that's forming. It's called a thrombus. And it's like blocking blood supply, or it can be compression from the outside. So something's growing from the outside, or it had some kind of trauma, some kind of injury that's like making the vessel get squished. Lovely, next one. So acute coronary syndrome is an umbrella term. So it's pretty much acute is like a sudden onset thing. So it's a sudden onset of reduction of blood supply to the heart, usually because of the coronary arteries. So in terms of blood supply to the heart, you have 3 main ones on the diagram on the right. So you have your right coronary artery, which is this one, that goes down there. Then you have your left coronary artery, which is up here, and then it divides into your, what we call your LAD. So your left anterior descending, or your circumflex, which goes around. And these are like the big three main ones that you'll come across. And the main ones we'll be discussing for these conditions. So for ACS, that includes STEMIs, NSTEMIs, and unstable angina. So STEMI is just like ST elevation heart attack, and non-STEMI is like non-ST elevation heart attack. So in your ECGs, you have that like ST little bit, and if it's like up, it's a STEMI. If it doesn't go up, it's an NSTEMI. And kind of how do we know that someone has acute coronary syndrome in general? Like in general, if they come to the hospital and they complain of chest pain, you're like, okay, they have acute coronary syndrome. And then later on, you might do some tests to determine like which type they have. It's like, it's an umbrella term. All right, lovely. Next slide.
Because I haven't done ECGs yet, Johnny.
They haven't at all? Oh, okay.
ECGs here. Do you know what we're talking about?
This thing here is an ECG.
No. So yeah.
Well, you'll become really familiar with ECGs. There's like different kind of parts of it. We have, we call like the P wave, which is this thing, QRS, which is the spiky thing, and then this bit over here, which we call ST, because like it goes from that thing over here is an S, and that's like a T wave. So ST is like the line. You'll go over ECGs a lot. The first time, I think we had like a clin skills session the first time we were exposed to an ECG with like Nadia. It's a lot. They go through like all these different patterns. Don't freak out too much, because once you finish that session, you've pretty much learned, or you've been exposed to everything there is to know about ECG. So the more you go over it, the more familiar you'll be with it. So ST elevation is just talking about this bit, which is supposed to be like there, kind of like on baseline, and when it goes like all the way up, not on baseline. Yeah, thanks, David, for defining them down. Pretty much if you come to the hospital and they're like, oh, I think you might be having some heart rhythm or heart attack problems, they'll put like little leads on you and hook you up to an ECG. There are like different lead like placements, like where they put the wires, and that's probably a very high yield thing to keep in mind. So like when you're taught it, I would write it down somewhere and put it up. It's like which, there's like the leads are numbered and like which direction of the heart they're facing. I remember I had to like memorize that for the exams. It's a bit stressful. So ACS, acute coronary syndrome, you say have ST elevation and then non-ST elevation, pretty much is what those two paragraphs mean. Generally, if you have a STEMI, so if your ST is higher, it's generally a bit more severe, there are a bit more complications, so we're usually a bit more worried about it. If your ST is normal, down, we're still like worried, you're still like, might be having a heart attack, but it's generally less problematic. Next slide. All right, so you've come into the hospital, you've complained of chest pain, they're like, okay, you have ACS, acute coronary syndrome. But how do we tell if you're having a heart attack or not? So pretty much to have a heart attack, you have to fulfill these criteria. And a heart attack, just like FYI, is just death, necrosis of like your heart muscle cells. That's like what a heart attack basically is, because like the blood supply isn't going well. And there's two parts of the criteria. The first part, and which you have to have, is a significant change in what they call a cardiac biomarker. So the most common one that comes up is troponin, and it has to be like in like a normal reference range, it has to be like on the 99th percentile. So it's like way out of, like way on the borders of the normal reference range. So that's the first thing. If you don't have that, bad luck, you're not having a heart attack. The second thing is you have to fulfill one of those 5 blue kind of criteria. So other symptoms of ischemia, ST changes, some development of some QAs. There's some like visible myocardium loss. You can see like a thrombus forming, like little clot things. So one of those 5 things you have to fulfill as well. You don't really have to know those 5 things from memory. At least you weren't tested on it. You are tested on troponin though, so just know that that's, I guess, a marker that you might be having a heart attack. Lovely. Next slide. Now, as you can see, that previous slide when I was talking about cardiac biomarkers was slightly vague. That's because you can use other things apart from troponin. So troponin is the one we love, but sometimes for whatever reason, they might be having some other conditions, which makes you think troponin is unreliable anymore. So there are 2 other biomarkers for heart attacks you can check that are most commonly used, and that's myoglobin or creatinine kinase. So myoglobin is a heme-containing protein in the heart, and it's released into the blood after a heart attack for a very short period of time, so 1 to 2 hours. So it's kind of a problem that if you've come to the hospital like 4 hours after a suspected heart attack, you won't be able to find it anymore. But it's good for like early detection. And the other thing is creatinine kinase. It's also released in the heart and skeletal muscle, and it exists in like those 3 forms that are specific for heart. So BB, MM, and MB. Those are just isoforms. So those 2, yeah, you can check them out. But as a general rule, we go for troponin unless otherwise stated. All right, next slide. Like I said though, troponin can be released in other circumstances. So if you do have a patient that kind of fulfills one of these criteria, it's important to keep that in mind. So the big reason troponin is released is in response to ischemia or stress. So a reason might be like heart failure, and the troponin's release is like a biomolecule. Sepsis is another reason, arrhythmia, so like an irregular rhythm, or any like kind of lung vessel complications or pulmonary complications. Sometimes drugs can affect troponin, and sometimes renal problems. So if you have like renal failure or you're getting like really old. So on the right is kind of a diagram they sometimes use in hospitals. So if you present with like kind of mild chest pain, the troponin levels are normal, ECG is normal, you probably have a non-cardiac thing, kind of obviously. Whereas if you have, quite severe chest pain, your ECG is still normal, or no, that's not normal, it's got the depression there. And you do have troponin, you could be like one of these 3 things. Or if your ST elevation is way up here, and you have a huge amount of troponin, you're probably having a heart attack with an ST elevation. Lovely, next one. So those 3 we spoke about before, that was for a heart attack. The other common problem you'll come across is heart failure. So David kind of touched on like kind of what heart failure means, like when it's not just pumping properly. There are 2 biomarkers we talk about. The first is BNP, which is found originally in the brain, but it's also located in the ventricle of your heart. It's kind of released if the heart's under like stress, so it has like pumped so much, or stretched, like it's being stretched to facilitate the pumping. And the other protein is C-reactive protein, which I had to learn about again because I forgot about C-reactive protein. So BNP, it causes vasodilation, so it causes your vessels to get wider, and it causes you to pee a bit more when it's released. And that's, I guess, all to decrease the pressure coming in. Why we do use BNP is when it's like digested by the body, its end product is something we call NT-proBNP, and that specifically is what you're looking for in heart failure when you're trying to see, does a person have heart failure? For the C-reactive protein, it's acutely released by synthesizing the liver. It's stimulated by inflammation cells, specifically interleukin-6. So if you have like an inflammatory response, chances are C-reactive protein will be released. And it binds to dying cells, which is why it's useful in heart failure, because some of the cells are dying, which activates the complement system. And it's also thought to predict future heart attacks, which is interesting. So they found that people who have high C-reactive, they might have heart failure, they might not have heart failure in particular circumstances, but their chances of a heart attack goes up around 60-fold. So it's thought to predict it in the future. So we'll see what science comes up with for that. Next slide. And the last dot point was kind of just about changes in the heart from a heart attack. So I guess the first change is that your heart cells have been dying or they're dead. And what they're replaced by is kind of this like fibrous sort of scar tissue. So in here, that's your scar tissue that's replacing the healthy cells, because it's really hard to get healthy cells to grow back again. The other thing is that you might have compensation. So you might have the healthy cells get a bit bigger, and have to do a bit more of the work. David, I love your Google browser, but can we go back to the PowerPoint? That said though, we can just search stuff up. I'm cool with that too. Granulation tissue, so that's kind of this thing over here. So this on top is healthy cells. That kind of bunch is inflammatory cells, because when like cells are dying, that causes an inflammatory response to come. Congestion, like a lots of buildup of fluid, and then just in general inflammation response. So a bunch of neutrophils coming to the area to see what's going on. And last one. So just emphasizing those changes were all for heart attacks. On the next slide, it's just for talking about heart failure. There used to be acute heart failure. People don't really get acute heart failure anymore. When we talk about heart failure, we usually talk about chronic, and that's because of good medications, people kind of aren't dying from acute, and the acute becomes a chronic thing. For heart failure, we can have like kind of two main, in chronic heart failure, we have kind of two main problems. We can have a problem with systole or a problem with diastole. So in systole, it's not contracting properly, which means we have a reduced ejection fraction. But you guys haven't done ejection fractions, so ejection fraction, it's going to be ejection. No, it's not drawing. I can't draw ejection fraction. It's pretty much stroke volume, so how much is coming out, over end diastolic volume, so how much is left after you squish stuff out. Stroke volume over end diastolic volume as a fraction, so times 100. So in systole, because you're not, I guess, contracting properly, you have a lowered ejection fraction. You have a lowered stroke volume. Whereas in diastole, technically the contraction's like okay, but the problem is your ventricles aren't filling like accurately. So your fraction's okay, like your ejection fraction's okay because your stroke volume's okay. It's like proportional, but you're just not feeling it properly. So it's like lowered overall, but your proportions of each other is okay. So yeah, that's something that will probably, hopefully, be covered in kind of the next few weeks. But yeah, just keep in mind ejection fraction. I think that's all I had to say. David, do you want to add anything on that?
No, I think that's great. So this was hard to make, primarily because you know all of it. So I did my best to not be condescending. I guess the only new thing that happened this sem is, so Katja talked about how C-reactive protein could be predictive for future MIs. And I think one of the mechanisms that underlie that is recently atherosclerosis has been discovered to be quite a significant inflammatory condition. So typically, and maybe in SEM 1, we learned it was primarily due to cholesterol or LDL buildup in the endothelium of blood vessels that led to plaque buildup and ruptures. But now it's being discovered that there's quite a significant amount of inflammatory response to that. And the reason why is there was primarily young 20-year-old females who were presenting with acute myocardial infarctions, and they kind of thought that was to do with inflammation, but that's being generalized a bit more. These are some of the learning outcomes. Again, I reckon you know most of this, like what is atherosclerosis and plaque formation, mechanisms that contribute to plaque rupture. Yeah, with some of the medications are relatively low yield as well, but we'll go through this. It's not too bad. It's a bit of an ugly presentation. Apologies about that as well. But the risk factors are essentially high blood pressure and high cholesterol. And we're just going to recap lipoproteins for a second. So these are in descending order of size. Chylomicrons and VLDLs are primarily tags, whereas LDLs and HDLs are primary cholesterol. Chylomicrons and VLDLs are too big to go into the blood vessels, so they often drain into the lymph, and then they get recirculated into blood vessels. Importance, that only new thing here, I reckon, would be this APB100 ligand for LDL reuptake. And what's important, probably more important later than now, is you did familial hypercholesterolemia in SEM1, and that's essentially just a defect in LDL receptors. So over here, you can see you have this APOP100 receptor. It engages APOP100 ligand that engages with the LDR receptor. It's kind of endocytosed and recycled, often through the liver. If you have a defective APOP100, it can't be recycled. So there's no negative feedback for the liver to secrete more cholesterols. It doesn't know how much, it doesn't know there's a lot of cholesterols in the body. It thinks there's nothing. So it accelerates a lot of cholesterol production and has like really high risk factors. This APOP100 ligand is an LDL and VLDL. HDL is thought to be protective, not completely understood, but it has quite a high density of cholesterol. And this is just showing you, again, this is revision. I got this from Leningus, but you have your chylomicron here. It's drained into lymph. Then it's going to be circulating your capillary, where it will react with lipases and form into free fatty acids. The remnant will go into the liver, where it will be transformed into VLDL, which will also undergo like pancreatic lipases, I think, and those will be converted to IDL. Then eventually you get LDL. LDL is your bad cholesterol. Your LDL can be oxidized by macrophages and endothelial cells. Those macrophages will become foam cells, and they can release a lot of inflammatory mediators. It's not completely understood why, but HDL can come in and kind of I think it estrophizes the cholesterol, which reuptakes it back to the liver. Again, really, you know this, but most high yield LDL, high plasma LDL is associated with the deposition of atherosclerotic plaque, which is behind the mechanism, and there's a positive correlation of HDL, which limits atherosclerotic plaque. So here you can imagine that you've had your LDLs disrupt the endothelial surface. They've been ingested by macrophages, which have become foam cells, and they lead into this buildup of plaque, which can occlude this vessel. And so Katja in her slide here have these different sorts of conditions. So this UA, or unstable angina, stable angina generally is often caused by occlusion of the vessel by the coronary artery, so it reduces oxygen supply, but not totally. So when people exert themselves and they have a higher oxygen demand, then that occlusion makes a difference, but when they're resting, it usually doesn't. This is just again showing you, so I remember a question about it being in the intima. I don't know if it was in an exam, there was some question somewhere, the practice exams, that said this plaque buildup is in the intima, which is the outer layer of the blood vessel. You can see inflammatory mediators. So a disruption to this endothelial surface will lead to the exposure of adhesion molecules, which can recruit monocytes into the tissue. Into the tissue, they'll differentiate into macrophages, where they'll ingest cholesterol or LDL. They'll become foam cells, and they'll kind of build that plaque over here, which you can see, and that plaque grows and grows and grows. It has a fibrous capsule that protects it from rupturing, but the inflammatory process degrades that capsule, and eventually it can rupture. If it clots immediately, it can form a thrombus that completely occludes the vessel, lead to infarction. Or as some of it can fleck off, you can have flecks flicking off as emboli. Emboli just means clots that travel around, and these can cause infarction in other parts of the body, which is another learning outcome, which is understanding that where it infarcts determines the symptoms. So if it infarcts in your brain, you can get a stroke. If it infarcts in your kidneys, you can have kidney necrosis. So I'm sorry, this is really ugly, but this is this lecture summarized. The vascular cholesterol is uptaken by LDL, which infiltrates endothelium, and it's phagocytized by macrophages will become foam cells. The monocytes will be recruited into arterial walls. The monocytes are recruited by inflammatory signals sent by LDL or chemotactically. These monocytes will differentiate into macrophages, and macrophages are quite potent secretions of inflammatory mediators. So these inflammatory mediators will lead to the differentiation of T cells to become Th1 cells, which are further pro-inflammatory cytokines. Don't get too worried about this yet. And then finally, a formation of fibrous cap will try to stabilize the underlying lipid core, but inflammatory signals do affect the cap. So inflammatory signals can decrease collagen synthesis or lead to degradation. And then a rupture may occur at the site or flicking off. So this is from a textbook summary that I thought was a bit more in depth, but also I'll just do it so it's more understandable, but then you don't have to worry about it ever again. So what's going to happen is if you have a lot of like oxygen species or a lot of cholesterol, that can lead to damage to the endothelium. And once you damage the endothelium, you're going to have an increased expression of adhesion molecules. Those adhesion molecules are going to be involved in recruiting monocytes and LDLs, essentially. What it'll also do, though, is the endothelium has an important function in releasing nitric oxide, which kind of protects the integrity of the endothelium. It prevents adhesion to the endothelium and kind of protects it. So when you're damaging the endothelium, you're both expressing adhesion molecules and reducing nitric oxide. Monocytes will cross into the intima and differentiate into macrophages, phagocytose LDL, become foam cells. They'll aggregate on the cell wall and form fatty streaks. And then the fatty streaks will slowly grow larger and larger and larger. And the inflammatory signals, primarily being sent by the macrophages, are going to lead to a proliferation of fibrous and smooth muscle. So the plaque is going to grow and grow and grow. This is the last slide of this. Eventually, the plaque can occlude the vessel, leading to symptomatic conditions. And that's one mechanism. The second mechanism is the arterial wall itself becomes more rigid. And it does that through sclerosis, through the deposit of dense connective tissues that is part of the inflammatory response. And remember, fibroblasts are an important part of healing with your first intention and second intention healing. So they would make the arteriole become really stiff and rigid. Calcification occurs as well when it interacts with the cholesterol. So what you can then have is plaque protrusion that exposes rough surfaces to the flowing blood. And when you've like exposed your endothelium, you can remember you have your von Willebrand fractures and the collagen linings. Those can activate platelets, which can trigger a coagulation cascade. And that clot can occlude the vessel or flick off as an emboli. HDLs are usually able to absorb the cholesterol. So you've essentially got the key concepts. It can affect the branchial bowel, carrying where it goes. The rupture of plaque can lead to thrombosis. Now we're going to talk about the treatments, which is new. There's two primary ways you try to treat. One is revascularization. Usually you do that with stents or angioplasty, which is you can either put in a metal thin to, like if the vessel is being occluded or the plaque is ruptured, you can either in angioplasty put in a balloon and pump up the balloon to keep the vessel patent, or you can do it like with a metal rod as well. You can also use drugs such as tissue plasminogen activators. The thing with these is they have to be used quite quickly. They can break clots. They're very narrow window of effect, and they're similarly used in strokes. So tissue plasminogen activator, if you remember from all the way back, plasminogen converts to plasmin, and plasmin dissolves clots. So tissue plasminogen activator will convert that. Sorry, I meant to write tissue plasminogen. So it's really indicated, it's quite good for AMI, so it's indicated within the first 12 hours. With strokes, with 4 hours, it becomes less. And pulmonary embolism is also indicated, which are kind of emboli, often from the legs, which go up into the lungs. Adverse effects are bleeding, which you can imagine if you're breaking up clots, you're going to have increased bleeding. And also there's another type of stroke caused due to hemorrhage rather than clotting, which I'm supposed to understand, but you're not yet. Treatment for atherosclerosis is when essentially just to reduce the amount of lipids circulating in the body. So you give statins, which are HMG-CoA reductase inhibitors, which you can remember from SEM1, and you can also give antiplatelets and anticoagulants. That's our presentation for this week. So we had a question about how to study for the CIP.
Oof. Wait, which system do you guys have?
Just a question, sorry. Yeah. Is it cardiac or is it MSK? Oh, good. Yeah, the cardiac one was really hard. The MSK one wasn't, so you're not in as much trouble. The CIE, you 100% get questions wrong, so it's generally not as high standard. The way to study it, have you done the formative one yet?
Maybe that is the formative one.
I remember the cardiac one being, we are formative on the 6th. So the cardiac is the formative one, and that's really hard, and that's going to scare you. The way that I recommend studying is, I don't know, I just think of common musculocutaneous conditions like rheumatoid arthritis and stuff. And then I go on up to date, and that breaks it up into like epidemiology, drugs, anatomy, physiology. And because all it does is it breaks it up in all out, like anatomy, physiology, presenting, examination, pop health, etc. So if you just have one slide on a condition, it's an ICL. It's essentially an ICL summary. So if you do an ICL for each condition you can think of just briefly, that'll probably be pretty fine. But ultimately, the MSK one wasn't too bad.
Yeah. Do the clinical skills quizzes? They copied some of the like patient background when they're like, oh, you know, a 49-year-old lady presented with like swan neck deformity. They had a couple of the same ones in the actual ones.
I'm going to do the second year ones
now. Yeah, same.
We need to go through all our ACL. Oh, no. Do not go through all your ICL cases for the CLP. Just think of common MSK conditions and then briefly read about them. Know how do they use, what are buzzwords associated with them for presentation, examination? Do they affect men or women? Is it affecting bones or joints, the leg or the arm? It's not too bad.
Yeah. You can search stuff up. It's perfect.
You recording? No, you can't search stuff up.
Imagine.
But yeah. How many conditions should we prepare roughly? I think there's
10, do you think?
Yeah, that sounds 6 to 9, I reckon. Yeah, I've never heard of anyone preparing for a CIP before, I must say. So if you do anything, you're ahead of the average. But yeah, if you just, I wouldn't necessarily think I must think of 10. Just think of the most amounts. Let's stop recording for a second.